Well, good afternoon, everyone. We have put together a sort of dream team of global expertise on mental health, and we're going to have a kind of informal chat as one can do in a webinar, and try and get some perspectives from people who have so much expertise and so much experience that we can only learn. It's my real privilege to introduce Professor Vikram Patel, who, as the joint leader of the Mental Health Innovation Network, is really, in my view, one of the leading lights on mental health. And it's a real privilege to have him guide us and the team. So we've got Vincent Leclercq from France. He's the Deputy CEO of Coalition Plus, vast NGO experience, and also really an expert on chemsex. And we look forward to hearing from him. Professor Melanie is a psychiatric epidemiologist. She's based in the UK, but she has extensive work in Zimbabwe and looking at interventions and whether they work. Felicia Browne, again, welcome from RTI. She really understands a lot of key populations with expertise in gender and worked extensively in both the USA and South Africa. Robert Remien, who you will all know, a professor in the USA, an advocate and a mobilization person from very early on, as well as a very high level expert, and looking at the intersection between mental health, HIV prevention and care. And finally, we're really thrilled to have Professor Peter Reiss, who is a clinician with vast oversight in Europe, in Amsterdam, where he works, chair of clinical trials. And he's really one of the sort of go-to clinicians, and his views on mental health is really what we want. So Vikram, over to you. Challenge our participants and see what fascinating lessons our audience can learn from them.
Thank you so much, Lorraine. I agree with you. This is such a distinguished panel. But what's more important is that each of our panelists represents such a diversity of the stakeholders who are concerned with HIV care. One of the most commonly used slogans in the global mental health field is that there is no health without mental health. And what I'm hoping that this panel will explore is the interface and the contribution of mental health to the overall well-being of people living with HIV. Peter, I'd like to start with you. As a clinician with such extensive experience of working with people living with HIV, what has been your experience on the relevance of mental health? And what are the resources that you deploy to address mental health challenges in the patients you care for?
Well, thank you, Vikram, for the question. I think it's a tough question because I'm an internist, infectious disease specialist, and although I think we've in the clinic always recognized the importance of mental health, I mean, right through the whole epidemic, I don't think we've necessarily, as biomedical clinicians, been very good at addressing the issues. And I think to this very day, I mean, I've stopped doing clinic a couple of months ago, but to this very day, we struggle in clinical practice in our clinics, in our outpatient clinics, to find ways to practically, as infectious disease docs, address the issues. And we try, I mean, we've tried over the years. We try to develop consultation services where we find mental health experts who are interested in the crossroads between mental health and HIV and develop systems to refer our patients to. But we've never been able, and when I say we, I think I hear the same exact stories from colleagues in other countries, both in Europe and elsewhere, to find these practical ways of either addressing very simple mental health issues ourselves as infectious disease docs and having the easy to refer channels for people that we think need more expertise. So I think the recognition is there on everybody's part, but turning this into practical solutions that work in everyday busy HIV clinics I think is still a different matter. But this is the clinical practice. And the only other thing I would say is that, as you know, I've been doing research, clinical research on HIV and aging for a long time, and we've recognized, of course, that long-term comorbidities play a role. But again, in the research area, I see the same thing, that mental health is sort of the underdeveloped area that is being addressed. And again, we struggle to find the right people to talk to and say, well, how do we actually integrate assessment of mental health in a practical way in our research studies? So, and everybody, you know, everybody would love to do it. And the other thing which I found, which has been, I mean, I'm definitely not an expert, but I was intrigued by literature on the interrelationships and also the biology linking mental health issues such as depression, depressive disorder, anxiety, stress, and the potential effects on the cardiovascular system and the underlying biology. And that is really, I think, a very intriguing field, which I don't think has been studied very much yet in the context of HIV, but would be something to pursue. So
Thank you, Peter.
For a moment.
Thanks, Peter. I mean, I think the points you raised, the point about what can you do practically in the real world coalface of HIV care that addresses mental health. And I think the point you made that the acknowledgement of mental health as being a very important part of the well-being of people living with HIV is something that you and your colleagues in HIV care are already doing. The challenge you face is, as you describe it, the practicalities. What kinds of mental health care can you give in these sorts of settings? And importantly, also, what are the practical referral pathways for people who live with mental health problems? And I'm hoping very much that some of the other panelists who have extensive experience in low resource settings will actually talk about how they have approached this issue in parts of the world which have very few mental health professionals. And hopefully we'll circle back with a further discussion later. Let me move on to the next panelist, Vincent. As an advocate who works in community contexts, I'd like to hear your thoughts about how mental health interacts with the risk of acquiring HIV infection and then the course of HIV infection. We've heard about biological factors that Peter spoke to, but I'm wondering, what are the other social factors that you encounter that can help us understand the relationship between mental health and HIV disease? And what do you think the HIV community would value in terms of support for their mental health? Vincent.
Yeah, thank you for inviting me. Well, we have knowledge on the relation between mental health and the risk of catching HIV. It's not something new, but with chemsex use, we have a good illustration of that relation. For example, we carried out a study during the COVID-19 epidemics on how people engaged in chemsex had lived the first lockdown in France, and the results were very interesting. For example, we had people who had some kind of regulation mechanisms on how they would deal with drugs and how they would deal with chemsex use, and it's just all blew up during the COVID-19 epidemics. And we know now that being engaged in chemsex is one of the risk factors of catching HIV, HCV, and STIs. And this is, in my opinion, a good example of how the way you feel the context and all the interaction with the context, how it can have an impact on your risk. And regarding your second question about what the community value in terms of mental health support, I will also talk about what happened during the COVID-19 epidemics. I have been amazed of all the solidarity within the HIV community. For example, belonging to one of the affected HIV community was a balanced experience during lockdowns. On the one hand, all your pre-existing risk factors would increase, such as poverty. We have noticed that. But at the same time, belonging to this HIV community, being connected to all these HIV organizations was a good way to have support of your peers. I've noticed many HIV organizations providing support, people calling each other's, taking news on how you're going. And this, I think, being connected is what is the most valuable thing within the HIV community.
Thanks, Vincent. You know, when you use the word peer support, I wonder whether that was a potential strategy that could address Peter's challenge about the fact that he faces, you know, a question about who to actually refer people with mental health problems to. And I wondered about the role of peer support and particularly the opportunities from global mental health that show that with adequate thought, it is possible for people without a mental health professional background to deliver effective interventions. But I'm running away with myself here, and I'm looking forward to the panelists who will speak with a lot more knowledge about that particular area in a moment. But first, I'd like to turn next to Felicia. Felicia, as we heard in your introduction, you have worked extensively on issues to do with the interface between gender and HIV. And I wondered whether you could explore from your experience how gender issues are linked to the interface of mental health and HIV. And furthermore, in your experience, how have health systems understood and reacted to these considerations? Felicia.
Great. Thank you for that question. So just my experience is with populations who use substances. So that's my framing of it. I think that's just important to say, particularly with adolescents and young adults. And so I think there are a few things that come to mind with that question. I think the first is we see that there's sort of an understanding of mental health with certain populations that that this idea that health is part of mental health and well-being. And so, you know, when we ask participants about their need for health services, we find that sometimes they say, you know, they don't need health services, but then when we further probe, we find that they say they need things to deal with anger or, you know, anxiety or depression. And so I think one of the things that we're really trying to address is this understanding of mental health. And then also the importance of stigma. I think there's still a lot of stigma, particularly with some of the communities in which we work with women. And this idea that either women should be able to handle everything, that seeking health or seeking services is sort of outside of either their beliefs or their faith. And so I'm really trying to lessen the stigma of just mental health in general and also getting help for that. And then the other thing that we see a lot of is, so in the work that we do with women who use substances, we find that we find that they use substances for many reasons. You know, either they're sad or depressed, stressed or angry. And we also find that, you know, within these populations in which we work, that women differ, right? So I think sometimes when we talk about women who are at risk or women who are living with HIV, sometimes we think about it as a sort of one group, not recognizing that even within this group, there are many variations. And so we've done a lot of work in trying to understand the differences in mental health needs and the differences. So for example, I think there are a lot of social determinants such as incarceration status. We find that with women who have been previously incarcerated, they have greater depressive symptoms, anxiety symptoms, post-traumatic stress disorder symptoms. And so we're also trying to think about ways that we can respond to the needs even within sort of these really specific or small populations in which we work. And then the last thing I think that is really important, I think it addresses sort of this issue of stigma and understanding of mental health, is that we try to do a lot of referrals and linkages to systems. And so whether that's even in instrumentation, so having prompts and probes where, you know, at the end of the instrument, participants can get active referrals to these organizations and resources, or at the end, just even posing those questions about service needs. And as part of that referral system, depending on if they're in our intervention, we can either physically take them to the service or call on their behalf. And so really creating that linkage. But I think the other question about whether, you know, whether those resources are available. And I think that's the one thing that we also try to make sure that we're knowledgeable about, because I think the one thing that we're concerned about is if we're referring people to something and either they are overbooked or things have changed, then that doesn't help them, right? And then they're not going to follow through with those services. So we always make sure that we're up to date on the latest and greatest of services and any changes. And I think particularly now in the midst of COVID and how things have changed, it's really important that we continue to do that. So I think those are some of just the things that we sort of noticed in the work that we've done with women who use substances. And I think there's this whole other thing also too about some of our couples work too, and how do we deal with that in a partnership as well.
Well, thank you. Thanks a lot, Felicia. Thank you, Felicia. I've been reading a lot. I'm in India right now, and I've been reading a lot about how COVID has affected the vulnerability of women in an incredibly patriarchal country in terms of, for example, their autonomy, their abilities to actually manage the multiple responsibilities that they've had to deal with, but above all, of course, their exposure to interpersonal violence, and knowing how much this also affects their sexual reproductive rights, and therefore also potentially their risk for HIV. This is, of course, a big question for people who are concerned with gender and health in India, and I wouldn't be surprised if that's also something that is also relevant in many other parts of the world where these issues are very prevalent. But hopefully we'll circle back to that issue in the final few minutes of this panel. Let me move on now to Robert. Robert, we've heard about some of these practical challenges that people are facing in addressing mental health problems. The question that I think a lot of people ask is, actually, do interventions for mental health problems work? And I'm aware that you, along with Melanie and others, recently edited a special theme issue of the Journal of the International AIDS Society, which was in fact devoted to the interface of mental health and HIV. I wondered from your experience of working in low resource settings, but also, of course, the experience of producing this excellent series of articles, what can you share with us about the effectiveness of specific interventions for mental health problems, and what are your observations about how they work in very diverse global and population contexts? Robert.
Thank you, Vikram. Thank you for the question. Thank you and Lorraine for inviting me to be part of this distinguished panel. Pleasure to be with you all. I think I would most fundamentally answer your main question to say that people should be aware that when it comes to people living with HIV specifically, and that's a lot of what we're talking about, that the evidence-based, the effective interventions we have for people with mental health challenges and problems, ranging from psychopharmacology to cognitive behavioral, motivational interviewing, as well as mindfulness and stress reduction interventions and harm reduction interventions, they work more or less as effectively in the context of HIV as outside of the context of HIV for the general population. So that's just a basic thing. People shouldn't think there needs to be something totally unique because of HIV. And in fact, research shows there have been meta-analyses and systematic reviews looking at the range of evidence-based interventions among people living with HIV, and they find, moderate, just like with the general population, not everyone gets the full help they need, but we have moderate effects across the board. The challenge, of course, is scaling this up. I mean, it's already been mentioned, we have a paucity of providers globally, not just more so in resource constrained settings, but I mean, I live in New York City in the United States of America, and our people who need mental health care struggle to find it efficiently. But the evidence-based interventions that exist, it's important to also note that many of them are manualized and tailored across multiple cultures and languages. And so when we talk about task sharing, there are people with a range of background in mental health that can deliver these interventions. And so that's something. And the other thing is that for scale up, there's use of technology is advancing in terms of its ability to scale up and deliver some of these interventions. And then I think Peter mentioned, in HIV primary care, I think it's also important to note that all providers, even non-mental health specialists, can play a role. I think simply asking a patient when they come in for routine HIV primary care, How are they feeling? What is their mood like? And just a few queries about their well-being can go a long way for just the fact that the provider is paying attention to that. That matters as much as, do you have pain, or, is your heart okay? It's, how is your, not that they did say, how is your brain, but how are you feeling? And also providers can help guide people to needs they may have around other social determinants of health and mental health that might also support their well-being. And then, of course, there's the referral to a mental health provider for something more intense. So we have to look, there's a range of intensity of need, and that's part of the picture. And then I'll just sort of wrap up and say, back in the HIV context, they're in research and in practice, there are evidence-based interventions that are addressing things like adherence to prevention and treatment for HIV, while also tackling or treating depression. Melanie, who will be speaking, is one of the experts dealing with this kind of thing with some of her colleagues. So there is an evidence base there for in primary care of it, tackling behavioral health, which means someone's, their behaviors in terms of their physical health, but also their mood and well-being, that are effective and can be scaled up and delivered by a range of a cadre of people. Let me pause there.
Thank you, Robert. Robert, something you just said at the start of your comments, I think is perhaps one of the most important scientific epiphanies, if I can use that word, in the last decade and a half of mental health clinical research in low resource settings. And it is this, that mental health interventions that work in Western context, so-called Western context, also work in very similar ways. To the surprise of many people, actually, they work in very similar ways in very diverse cultural and social contexts transnationally. And I think this is a very important scientific discovery, because I think for a very long time, and I can certainly remember in the early years of my own career, that there were genuine questions asked about whether or not there was, whether these interventions traveled across cultures and contexts, whether they were generalizable, because there were concerns about the very different cultural narratives about mental health problems might interfere in some way with the effectiveness of these interventions. And I think you're absolutely right to emphasize that these interventions work in not only diverse contexts, but also in diverse populations, such as, for example, people who are living with HIV. And thank you for emphasizing that right at the outset. Let me turn to Melanie. I think, Melanie, we already heard from Robert about your experience of working at the coalface on integrating mental health care in a variety of different sectors. And we'd love to hear about that. What has been your experience of integrating mental health into HIV care? And apart from your own experience, do you know of any other exemplars which you think offer us great examples of how one can successfully achieve this goal? Melanie.
Thanks, Vikram, and it is really great to be part of this panel. I think that one of the key things that I have learned is that HIV clinics are very busy places. All the staff, have a lot to do. There's some very unwell people in there. And so when you are asking them to think about mental health, it is a big ask. And so something key that I have learned is that don't bother starting any research unless you think your intervention has a chance of being sustainable. So integration is the key facet, and sustainability, I think that has to be the starting point. And from that perspective, that means learn about the HIV cascade, understand what the national operational strategy is in the country you're working, and make sure that any mental health screening or intervention you're thinking about can connect with that existing cascade. So I'll give two examples from my own experience. Obviously, everybody knows about the friendship bench. When people come to primary care in Zimbabwe and the nurses pick up that they are thinking too much, or they've got recurring headaches or whatever, they can refer them to one of the grandmothers who's available, who's sitting on the bench, and they will use some simple problem-solving based therapy. What's fascinating is an NGO that I know called OFID, who are very, very big in Zimbabwe, who have managed to work with USAID and PEPFAR, and they have taken the CADA who normally go and check on the defaulters. That's a horrible word, but that's how people tend to be labeled. The people who don't pick up their HIV meds, the defaulters, and they are now doing screening using the PHQ-2. And so if they pick up someone who's screening positive, they can refer them to the friendship bench. So that's an example of integration actually happening before your eyes, that an NGO who works closely with government is actually picking up that. Just another example that we have been working on for the last 5 or 6 years is the whole notion of targeting people living with HIV who are already a priority to the government. And the classic group there is people with poor HIV disease control. So everybody has a viral load test, and everybody comes every year or 6 months, depending on the country. And that is a great time to intersect mental health with HIV, because it's already a priority to get people, support people to achieve viral suppression. So we have been working with the CADA who already do the testing and the counselling for people with high viral loads, and training them to do a very simple problem-solving based intervention, but with some other active ingredients learned from other interventions. So those are 2 examples, and just one very quick one, I think, of some charities who are working with youth, like Zvandiri, who already have adolescent treatment supporters, and training them as well to be more mental health aware. So perhaps I'll finish at that point, and then happy to say more.
Thank you, Melanie. I think one of the most important innovations that has come from your work and that of many other global health practitioners has been the demonstration that not only are clinical interventions effective in these diverse populations, as Robert mentioned earlier, but that using non-specialist providers, such as, for example, the example that, the friendship bench, grandmothers, with adequate attention to training, supervision, and quality assurance, can in fact deliver these interventions. And I think this is a transformative piece of evidence. For me, this is an implementation science evidence-based that a recent Cochrane review actually that just got published in the last few months has added up 95 randomized control trials of this approach of task sharing mental health care. And in my mind, there can't be a more immense evidence base and knowledge base to guide the scaling up of mental health care everywhere in the world. As we heard from many of our other speakers in wealthy countries too, there are huge gaps in terms of access to quality care. And I think the global south, I think, can teach the rest of the world how we can close the care gap for people living with HIV and mental health problems. With that, I'd like to, we only have a minute or so. Unfortunately, we will not have another round of questions, but instead what I'm going to do is invite my co-chair, Lorraine, to give some closing remarks on this fabulous panel. Lorraine.
Well, thank you, Vikram. There's a thread going through here of integration and of possibility and hope. And I just have one reflection. One is that we should open up our thinking that you don't necessarily have to have mental health interventions for mental health outcomes. Some people feel destitute and depressed because of poverty, for example. Well, if you deal with the poverty, their mood might just go up. Some people are stigmatized and therefore they feel awful. If you remove the stigma, you don't have to give them an intervention to improve their mood. You have to actually stop people stigmatizing them. So there's lots of out of the box thinking that we can do. And I think the integration idea is really the way forward. And I just reminded of the points that Peter started us up with. You have to have 3 stages. The first is you have to actually be open and willing to identify the issue. So you have to ask, you have to measure it, you have to incorporate it. Vincent was saying, we have to then reach out. I think there is a basket of care available. And you have to just be willing, as you know, Melanie and Robert were telling us, be willing to use it, and Felicia, keeping the lenses for different groups and different people. No one's mentioned children and adolescents. They have needs too. You know, I feel sort of optimistic, but I think we've got big challenges ahead. And Vikram, I think your words, which started the revolution of no health without mental health, really is the driving force behind this webinar and behind the future of well-being.
Well, thank you all very much for this engaging discussion. I wish we had a little bit more time so we could have a little bit more conversation amongst ourselves, but the is only for 30 minutes, and I think we're now out of time. Thank you all very much, and I hope our viewers will have found this conversation as engaging as I have.